The third lesson in this module on physical health and related low-incidence disabilities will cover traumatic brain injury. Traumatic brain injury was added as a separate disability category under IDEA in 1990. TBI is the most common cause of death and acquired disability among children in the United States. It is estimated that each year more than 1 million children experience a TBI, with 9 to 38% of them being referred for special education services. This wide range suggests that we do not have great data. However, we do know some students with TBI have significant learning problems, and the need for special education services that were not needed before arises. Traumatic brain injury means an acquired injury to the brain caused by an external physical force, resulting in total or partial functional disability or psychosocial impairment, or both, that adversely affects educational performance. The term applies to open or closed head injuries resulting in impairments in one or more areas, such as cognition, language, memory, attention, reasoning, abstract thinking, judgment, problem solving, sensory, perceptual, and motor abilities, psychosocial behavior, physical functions, information processing, and speech. The term does not apply to brain injuries that are congenital or degenerative, or to brain injuries induced by birth trauma. According to the IDEA definition, TBI always results from postnatal injury, and it must affect educational performance in order for a student to qualify for special education. Traumatic brain injuries result in temporary or permanent injury to the brain as a result of car accident, accidental falls, or wounds to the head that are not a result of congenital or degenerative conditions. Penetration injuries, such as gunshot wounds, lead to specific effects as a result of the area penetrated. Acceleration injuries, such as those acquired through an accident, result in damage throughout the brain. The initial site of impact is referred to as coup, and the second site of impact is referred to as contre-coup, where the brain is thrust back and forth. Results of TBI range from no effect to severe disability. Students with moderate and severe cases typically require hospital stays and rehabilitation. Motor skills return first, and cognitive skills return last. The most dramatic gains will occur during the first year, with skills continuing to return over a 5-year period. There are two broad types of traumatic brain injury, closed and open. A closed head injury is one where the skull is not broken open. For example, a boxer who receives a blow to the head may experience brain damage even though his skull is not damaged. An open head injury, or penetrating injury, results when the skull breaks open. For example, if a bullet wound to the brain caused damage to the skull as well as to the brain, it would be considered a penetrating or open head injury. Both open and closed head injuries can cause damages that range from mild to severe impairment. In the most severe cases, head injury can result in death. Usually an open head injury is more serious than a closed head injury, but that is not always the case. When we distinguish closed from open head injuries, we're referring to the condition of the skull. However, brain conditions are defined through the term contusion, axonal injury, or bleeding. Through neuroimaging scanning, one can take a picture of the brain and see what damage has resulted. A contusion means that there is bruising of the brain matter. There can also be bleeding with contusions, however, it is not generally a large amount. Axonal injuries affect the neurons in the brain. The last type of injury is evidenced when there is a large collection of blood, which is called a bleeding brain injury. Bleeding brain injuries tend to be very serious. Contusions and axonal injuries vary in terms of severity. In an axonal injury, the brain neurons have been affected. Brain neurons are critical to brain function because they are where information is exchanged in different parts of the brain. The neurons have stalks, which are also called axons. In an axonal injury, the stalks break off from the neuron. A large portion of the brain can be affected with an axonal injury. Compared to a contusion where bruising may be concentrated in one specific area, an axonal injury can affect the whole brain. Axonal injuries result when there has been fierce shaking or twisting of the head that causes the neural endings to be ripped from the axons. The key to understanding children with traumatic brain injury is that there is great variability in terms of functional level and emotional adjustment. One factor that's going to affect that variability is the age of onset. The age of onset is critical because it matters whether or not certain skills have been learned previously. If an individual has a head injury later in life, they may lose the capacity to do certain skills that they had previously mastered. A younger child may not lose as many skills, but of course, they may have a harder time in the future acquiring new skills. In terms of emotional response, the later on in life the injury occurs, the more aware a student may be of any changes. This can lead to depressions, changes in peer groups, and changes in personality and skills. Severity of the injury is another key component that affects variability in traumatic brain injuries. Some head injuries are not as severe, and a person may go through an adjustment period for 2 or 3 months. However, if the head injury is more severe, it can affect their previous learning. They may not read, understand abstract concepts, or control their motor and body functions as well as before the injury occurred. Hearing and vision may also be impacted, even if physiologically their eyes and ears are fine. The final variable that is important to consider is the extent of recovery. Some people recover quite well and seemingly regain their skills in a relatively short amount of time, while other people do not fully recover. What are the leading causes of traumatic brain injury? The number 1 cause is falls. The second leading cause is motor vehicle accidents. In the case of motor vehicle accidents, many times TBI could have been prevented if the child had been wearing a seatbelt or if the child's car seat had been installed properly. The third leading cause is abuse. Physical abuse can result in trauma to the brain, as is the case with shaken baby syndrome. There can also be accidents with firearms or other weapons that result in TBI. Such situations can be considered abuse or neglect, even though the injury was not intentional. The final cause is due to sports-related injuries. In terms of numbers, boys are twice as likely as girls to have TBI. Once again, males are overrepresented in this disability population. In terms of age range, the highest incidence is between the ages of 15 and 19. Motorcycle accidents are a leading culprit among that age group. Certainly, wearing a motorcycle helmet could prevent a lot of cases of TBI. There are a number of signs to look for between the time a potential injury occurs and up to 72 hours after it happens. If these signs are observed, there may be evidence of trauma to the brain, and it would be important to see a doctor. These signs include dizziness or lightheadedness, nausea and vomiting, blurred vision, increased sensitivity to lights or distractions, and/or loss of senses, such as smell or taste. Other signs of TBI include headaches and neck pain. Are they complaining that their head hurts and their neck hurts? Do they seem to be having difficulty remembering or concentrating? Do they have issues with thinking, speaking, or reading? Again, we're speaking of difficulties that they didn't show before. If they show fatigue, a lack of energy, or decreased motivation, that could be another sign that they might have experienced a traumatic brain injury. Finally, if they are showing changes in sleep patterns, that may be another sign. These signs are meant to be signals as an indication that someone may have experienced a traumatic brain injury. It's very important to realize that social, emotional, and cognitive deficits caused by a traumatic brain injury may persist long after a person's physical capabilities recover. Just because a person looks physically well does not mean that socially, emotionally, or cognitively they are well. One of the most common cognitive problems involves short-term memory loss. They may have difficulty repeating information that they just heard or showing mastery of new content. They may also lose themselves in conversations because they just have difficulty holding information in their short-term memory. Long-term memory can also be a problem. For example, students may not be able to recall details about their life that happened before the accident. Another area of difficulty involves concentration and attention. There may also be issues with planning, initiating, and following through with an action. Essentially, they may have difficulty organizing their thoughts and completing a sequence of actions. One of the most challenging limitations that might persist is poor self-awareness. Being aware of one's own cognitive limits and accepting the fact that you can't do things that you used to be able to do before the TBI can be quite difficult. Poor self-confidence and poor self-esteem is another persisting deficit. Social-emotional issues can persist long after the physical indication of the injury have passed and can cause depression and loss of confidence. Personality changes in people with TBI can also occur. An individual who used to be very patient now may be very impulsive and may not be so patient with others. Finally, TBI can cause epilepsy and also increases the risk of Alzheimer's disease and Parkinson's disease as time goes on. However, TBI affects everybody differently, and some people will recover without any loss of skills, health changes, or personality changes, and others will have long-term skill deficits, health concerns, and social-emotional adjustment problems as a result of their traumatic brain injury. There are several ways we tell what part of the brain is affected. The EEG measures electrical activity in the brain. The computerized axial tomography, or CAT scan, uses X-ray technology to produce virtual slices of the specific parts of the brain. These are the two most traditional techniques. However, if more detailed information is needed, then they would use the magnetic resonance imaging, or MRI, or fMRI. Finally, there is the PET scan. To do a PET scan, a small amount of radioactive material is inserted into the body, which produces a 3D image. The important thing for you to remember is that there are a variety of ways to get information about what part of the brain is affected by the TBI. A combination of these procedures will likely be used to determine the location of the brain injury, as well as give some indication of the severity of the injury. With medical advances, we can now get a good idea of what part of the brain was affected in a traumatic brain injury. Oftentimes, when you know what part of the brain was affected, you can predict what sort of adjustment problems the person is going to have. However, even as advanced as some of the brain scans are, it does not replace the need for an observational evaluation. A brain scan cannot say the extent to which the injuries will affect the individual. In terms of traumatic brain injuries, the frontal and the temporal lobe are particularly vulnerable. The frontal lobe is associated with personality, emotions, motor skills, problem solving, and reasoning. If the frontal lobe is damaged, one can expect problems in these areas. The temporal lobe is associated with hearing, language, and speech. It's also associated with executive functioning. Therefore, damage to the temporal lobe may result in impulsiveness and difficulties with organization and planning. The parietal lobe is associated with pain, touch, and speech, another part of the brain that's associated with speech. The occipital lobe is associated with vision, which if damaged may result in blurred vision or complete vision loss. The cerebellum is associated with balance and coordination. A person may not have any physical injuries to parts of their body, but they may begin to walk with a strange gait, or may have difficulty with balance and coordination because of TBI to their cerebellum. What is the prognosis for recovery for students with a traumatic brain injury? The answer is, it depends. It is very difficult to say what the prognosis for recovery is. I wrote on this slide that it is very variable. The prognosis depends on so many factors. These include the type and the extent of the injury, how rapidly people were able to respond with first aid, and the quality of the medical care that the person was given following the trauma, the quality of the rehabilitation that was provided, and the quality of the educational intervention that is provided as a person is recovering. Some people make a full recovery, some people never fully recover, and some people have to redefine who they are after the injury. Due to extended stays at hospitals and rehabilitation centers, it is important for educators to understand best practice for assuring successful hospital-to-school transition. Educators need to be involved during the hospital stay, regardless of whether the child will receive instruction in the hospital setting. This keeps the school informed of the child's status and also provides social-emotional support to the child and the family. School personnel should also keep updates on the student's medical progress. If the child is going to receive homebound instruction, it is important to try to keep those services as short as possible. The goal is to get the child back into the school setting, even if it is for a short period of time initially. After the student comes back to school, there should be careful monitoring of the student's progress. Home-school communication is very important. Next, someone needs to be assigned as the point person for coordinating and monitoring the transition. The key is to map out a plan for the transition and make adjustments along the way as needed. Finally, educators need to allow for reasonable accommodations. One accommodation that may be helpful is allowing the child to come to school for just part of the day. In a case where the child fatigues more readily than other children, the child should be allowed to go home earlier. We accommodate that by providing the child both in-school instruction as well as homebound instruction on the other part of the day. There may need to be some other accommodations made as well. For example, the child may need somebody to take notes for him or her, or the child may request some counseling to help them adjust to this big change in their life. The child may need to be excused from homework assignments. Schools shouldn't be resistant to providing reasonable accommodations based on the child's needs. As we end this lesson, take a minute to review the table. It provides a nice recap of the characteristics one might see in an individual with traumatic brain injury.